Hello, everyone. My name is Jayesh Dhanani. I'm an associate professor at the University of Queensland Centre for Clinical Research and a senior intensive care specialist in the Department of Intensive Care Medicine at the Royal Brisbane and Women's Hospital. I'm here to discuss and talk around the topic of inhalational therapy, especially in the context of a pandemic. We'll start with the case we need, actually, something that I was very passionate about in terms of looking after this particular patient. A 30-year-old lady that I looked after day 9 post multi trauma, uh, being invasively ventilated, developed a febrile hypoxic respiratory failure. She then had an initial therapy consisting of piperacillin tazobactam. Subsequently, a sputum microscopy reflected that it was a multi-resistant Pseudomonas infection that she developed. She was commenced on intravenous meropenem, but despite that, continued to decline even after 5 days of appropriate antibiotics. And hence, after consultation, was commenced on inhaled tobramycin at 300 milligrams BD. She defibrised quite rapidly after 36 hours of this treatment. After 3 days, she was beginning to wean off the ventilator. And subsequently, on day 7, she was extubated successfully off the ventilator and was discharged to the ward. Just demonstrating the significance and the effect of inhalational antibiotics, inhalational therapy in general for lung-like conditions. The advantages of inhalational therapy or aerosol drug delivery in general are you can actually get away with having a much smaller dose of a particular therapy. High local tissue concentrations could be achieved for maximal local effect and minimum systemic side effects because there's very little that gets into your blood when inhalational therapy is applied. Rapid onset of action because directly the drug goes into the site of action itself and also bypasses the first pass metabolism, thus giving the drug the maximum chance of clinical effect. When we consider the effect or the advantages of inhalational therapy, we find that the primary advantage is the ability to directly target the lung using smaller doses and less side effects, but also demonstrating a comparative pharmacodynamic effect using a drug like terbutaline, which demonstrated that when compared to other ways of administering the drug, such as, say, oral, subcutaneous, or inhalational way of delivering the drugs, the percentage change in the patient's clinical improvement was much better with inhalational therapy. It does and hence actually reinforcing the concept that local problem, local treatment. The points to discuss in this further discussions would be in the form of fundamental principles, the types of delivery devices available, the ways to optimize aerosol therapy, especially in the context of various respiratory supports, and the aerosol therapy, particularly in COVID-19 pandemics. So let's go through the principles of aerosol therapy. The key feature of any pharmacological therapy is to achieve adequate drug concentration at the site of action. And the conventional pharmacokinetic principles are in the form of absorption, distribution, metabolism, and elimination, also called as ADME. When it comes to aerosol therapy, the principles change to DAME, which is distribution or drug delivery, which takes precedence over the other aspects of pharmacokinetic principle, and therefore the rate limiting step for the clinical effect using aerosol therapy is drug delivery. Now, let us consider some of the factors that affect aerosol drug delivery. The key feature, which is identified over years of aerosol therapy and evidence building around this, is in the context of actually having the particle size distribution. So it is well described in literature that 1 to 5 micron particle size range is the optimal particle size range to have distal lung delivery, which is where the site of action is. When it comes to delivery devices, there are over the years a number of delivery devices have been developed, right from the first generation jet nebulizers, which are still in use, to ultrasonic and ultimately vibrating mesh nebulizers. The jet nebulizer working on the baffle system, the ultrasonic nebulizer working on the piezoelectric crystal mechanism, and the mesh nebulizer working on the palladium vibrating mesh technology itself. What are the differences? Let's quickly go through them. You'll find that compared to the jet nebulizer, the ultrasonic nebulizer generates much higher amount of delivered dose, but certainly of all the three generation of nebulizers, the mesh nebulizer optimally delivers the maximum amount of drug delivery to the site of action, and therefore is much superior in terms of its clinical effect. Admittedly, it's a bit more expensive as well. Having said that, one has to balance the clinical effect, the desired clinical effect, to the cost of therapy as well. When we try and look at the aerosol therapy with some of the respiratory support type devices, such as the mechanical ventilation, we find a number of factors that influence the drug delivery and drug deposition. There are some drug-related factors, device-related factors, ventilator-related factors, which includes mode, tidal volume, respiratory rate, flow, waveform, and trigger. There are some circuit-related factors as well. And ultimately, not the least, the patient also contributes to the effectiveness of delivery as well. So when exploring the effect of humidification, it is demonstrated that with humidified circuit, the amount of delivered drug actually reduces. And that's largely to do with the fact that the humidification, or the process of humidification, adds to the size of the particles. So when the particle size increases, it does actually cause more proximal lung deposition as compared to when the particle size are smaller, as in the dry circuit. When we look at effect of drug formulation, we find that the viscosity has a positive effect and almost an inverted U-shaped effect actually on the drug delivery itself, where as the viscosity increases, the amount of drug delivered increases as well. But after a certain amount of viscosity increasing, the viscosity leads to obstruction of these pores in the nebulizer and actually can reduce the amount of drug delivered as well. And therefore, viscosity comes with a inverted U-shaped curve in terms of its clinical effect actually as well. Some of the ventilator parameters of importance when it comes to drug delivery is the airflow rate. Again, very simple to understand, where the laminar flow is what we are aiming at. If there is a very turbulent flow, then the drug delivery is likely to be more proximal as compared to where the site of action is which is distal in nature. When the airflow rate is slow, the laminar flow is easy to achieve. Tidal volume is another factor. You have an optimal tidal volume of about 500 mils is what is required to actually have a distal lung delivery. Respiratory rate will have the same problem as the airflow rate, where if one is breathing too fast, then the airflow is likely to be very turbulent, and therefore proximal delivery or proximal deposition is more likely. When it comes to mode of ventilation, it is important to understand that a volume control mode seems to have a much more optimal lung delivery as compared to a pressure control mode. Yeah, another factor of consideration is the nebulization or nebulizer position in the ventilator circuit itself. As shown in the figure, we find that when positioned proximal to the ventilator, so closer to the ventilator, just before the humidifier, on the dry side of the humidifier in particular, the delivery is much more optimal as compared to inserting the nebulizer closer to the Y-piece, which interestingly, with a recent literature of a survey of practice, seems to indicate that the device is proximally placed closer to the Y-piece as compared to the optimal position, which is on the dry side of the humidifier. So another thing to consider when applying nebulization on a ventilator setting itself. When we use the nebulizer with a non-invasive ventilator, though, um, application of the or placing of the nebulizer closer to the mask, so proximal to the exhalation port, should deliver adequate amount of drug to the patient itself. And that's again intuitive, where if the exhalation port were to be on the other side having been put, then the nebulized drug would likely get exhaled and not be delivered to the patient. High flow nasal cannula. Now, this is a therapy that has evolved over time and has actually increasingly been used across critical care in a number of different conditions. Certainly, data suggested during the pandemic that a lot of patients who received high flow nasal cannula therapy ended up avoiding needing to be ventilated as well. And that's data that is similar to the non-pandemic that patients as well. So it is something that is being commonly used. But when we're using aerosol delivery with high flow nasal cannula, it is again important to place the nebulizer in the right way. So vibrating mesh nebulizer is the nebulizer to use and is best placed on the dry side of the humidifier. Some of the newer devices like the Evo 2 come with an inbuilt adapter, which is easy to actually use to slide in the nebulizer into the adapter without actually having to break the circuit itself. When using the high flow nasal cannula, it has been demonstrated that, again, at a higher flow rate, it is delivering less amount of drug to the lungs. And that's, again, intuitive, where higher flow rate will generate a lot of turbulent airflow and therefore resulting in reduced distal lung delivery as well. So low flow is actually better when using the high flow nasal cannula, especially in the context of using a nebulized drug therapy. When we use aerosol therapy for COVID-19 patients, it is important that being a once-in-a-lifetime event, initially we did not understand the mechanism. Now we understand that recognized key to transmission is aerosol dispersal, but it is from the patient, not from the device. There are a lot of aerosol generating procedures that occur in critically ill patients, such as intubation, bronchoscopy, and so on and so forth. The key principle, therefore, is to reduce the community transmission by reducing the fugitive emissions originating from the patients. And it's not the therapeutic aerosols which cause the aerosolization of these infected particles. It's actually the infections originating from contamination by the patients when they are coughing, for example, or originating from healthcare workers when appropriate antiseptic measures are not used during the therapy itself. During the course of the pandemic, it's interesting actually, a number of different agents have been studied, and it's only now that literature is coming out that inhalational therapy clearly is a alternative therapy for treating patients with suffering from pandemic infections. And so the latest data actually even suggests that we could have used unfractionated heparin, for example. A lot of direct antiviral drugs have been used as well. A lot of immunomodulators and mucolytics have been studied. And watch the space. A lot of data is coming out actually in the next few months actually from this study. The principles of using aerosol therapy in pandemic type situations are that a pressurized meter dose inhaler are no better than the nebulizers. So nebulizers can still be used quite effectively. Preferably use disposable mesh nebulizers, again, to reduce infection transmission. But if you're going to use reusable nebulizers, please make sure that they are adequately sterilized. Use adequate PPEs and social distancing, especially during therapy. And reducing formulations that induce coughing. Remember, coughing is one activity which will generate a lot of infected aerosols causing community transmission. So it's important to reduce the agents that can induce coughing during aerosol therapy. Some of the practical strategies, especially in COVID-19, mild conditions, we could avoid the nebulization as far as possible. But if you're going to use it, use with a mouthpiece or a high flow nasal cannula. Do not use face masks. The face mask have got openings through which a lot of nebulized drug and infected aerosol could actually cause fugitive emissions and cause community transmission. So it's important to reduce the face mask use in nebulization. Add the filter if you can, and I'll demonstrate in the next figure actually how an assembly can look like. So you have the um, nebulizer device with a mouthpiece and a filter, which will capture the exhaled drug and the exhaled infected aerosols, which will obviously, if it is captured in the filter, would reduce the fugitive emissions and community transmission. If it is a moderate type infection for the patient, then one could use a system like this where there is a high flow nasal cannula and a mask that covers the patient's face so that there is less risk of fugitive emissions. Obviously, negative pressure rooms and PPE are some of the other interventions one could use to reduce the community transmission. And then when the patients are really, really sick and are invisibly ventilated or non-invisibly ventilated, one could use the mesh nebulizers in line. And the advantage is that you don't need to remove it and don't need to remove the circuit and therefore reduce the risk of community transmission and fugitive emissions. Placing the nebulizer before the humidifier will improve the efficiency. You could add a filter to the expiratory limb. Certainly, physiotherapy and suctioning during aerosol therapy is not advisable, and wearing PPE and safe distancing always helps. So in conclusion, aerosol delivery in general is the rate-limiting step for optimal aerosol therapy. Mesh nebulizer optimally delivers distal lung delivery to the for the aerosol therapy. Consider the factors that could be optimized to improve the aerosol drug delivery. The cost benefits of a mesh nebulizer should be weighed against effective therapy and therefore reduced hospital stay. In the context of COVID-19, use a nebulizer with a mouthpiece when possible, inline nebulization when high flow nasal cannula are used. Surgical mask on high flow nasal cannula would be able to reduce the fugitive emissions. Using nebulization with adequate PPE in negative pressure rooms should reduce the fugitive emissions, and mesh nebulizers could be used with filters to again reduce community transmission. Thank you.